And we are back. We are talking about anemia. We're talking about drug-induced aplastic anemia. We're going to continue talking. If you haven't seen the first, or haven't heard the first fun-filled video, I recommend you to check out Anemia 1, especially if you're having difficulty falling asleep. Drug-induced aplastic anemia. Chloramphenicol has long been known to cause idiosyncratic aplastic anemia with an incidence of 1 in 20,000. Recall that the general incidence of AA is 2 per million, thus representing dramatic increase in risk. It is also known that high doses of chloramphenicol can cause dose-related myelosuppression. This effect on the marrow abates with discontinuation of the drug. Unfortunately, the idiosyncratic form does not resolve when the drug is stopped. Antineoplastic drugs are associated with myelosuppression, but this effect will resolve when the drugs are discontinued. Further, growth factors can mollify some of the adverse effects of these drugs. Gold salts used in the treatment of rheumatoid arthritis are also associated with aplastic anemia, as is quinacrine, which was used for malarial prophylaxis in World War II. Toxic chemicals. Benzene is used in the manufacture of chemicals, drugs, dyes, rubber, and leather goods. The suppressive effect of benzene on the bone marrow is dose dependent. In the US, government regulation has lowered permissible exposure to benzene, but in China, AA is 6 times higher than in the general population because of absence of safety guidelines. Viruses. Less than 5% of patients with non-A, B, C, D, and E hepatitis go on to develop severe aplastic anemia. In many instances, the hepatitis has resolved before the onset of aplastic anemia. There is a male preponderance, and approximately 90% of those affected succumb in less than 1 year. Fortunately, as with idiopathic, probably autoimmune AA, these patients have a good response to combined immunotherapy. A rare patient infected with Epstein-Barr virus has developed AA. It seems that this is triggered by an immunologic response and not by a direct effect. Radiation. Radiation has long been known to cause acute leukemia and aplastic anemia. The degree of myelosuppression and the ability of the marrow to recover depend on the dose and time frame of the exposure. Total body radiation at a dose of 1 to 2.5 GY causes myelosuppression and severe gastrointestinal symptoms, the latter because the epithelium is a rapidly dividing tissue like hematopoietic cells. A dose of 4.5 GY leads to death in greater than 50% of those exposed. Fortunately, these types of exposure are uncommon. Inherited bone marrow failure syndromes. There are a number of rare inherited causes of bone marrow failure that include dyskeratosis congenita, Fanconi anemia, and Diamond-Blackfan anemia. In Fanconi anemia, the affected genes participate in DNA repair, protecting the genome from agents that cross-link DNA. In addition to aplastic anemia, the other hematologic disorders associated with Fanconi anemia include myelodysplasia and acute myeloid leukemia. Patients with Fanconi anemia often have hyperplasia of the thumb, radii, and kidneys. Why some patients develop AA and other patients develop acute myeloid leukemia is not clear. In Diamond-Blackfan anemia, genes encoding ribosomal proteins have been identified in approximately 1/2 of cases. These patients manifest severe anemia in the first few months of life. In dyskeratosis congenital, the genes affected encode proteins involved in maintaining telomeres. This disorder is characterized by dystrophic nails, patchy skin, hyperpigmentation, and oral leukoplakia. AA occurs in the first or second decade. This is a very difficult form of bone marrow failure to treat, but androgens and bone marrow transplantation are being used. Unfortunately, even if bone marrow function is restored, the risk of cancer remains because of telomere damage. Recall that without telomeres, some DNA would be lost at the end of the lagging strand whenever a cell divides. Recall that DNA polymerase requires an RNA primer as a temporary placeholder to initiate DNA replication because DNA polymerase cannot initiate DNA replication itself. DNA polymerase needs to add nucleotides to an existing set of nucleotides. RNA primers bind to the parent strand of DNA and provide a site for DNA polymerase to start replication. Ultimately, the RNA primer will be removed and will be filled in with deoxyribonucleotides. Another problem for DNA polymerase is that it can only add nucleotides in the 5' 3' direction, and there must be an alcohol or OH group to attach the phosphate of the incoming nucleotide. Okay, let's repeat that paragraph, that section. Another problem for DNA polymerase is that it can only add nucleotides in the 5' to 3' direction, and there must be an alcohol or OH group to attach the phosphate of the incoming nucleotide. The primer on the leading strand will allow replication to proceed in the 5' to 3' direction, but the lagging strand is made in segments called Okazaki fragments, requiring the participation of multiple RNA primers. If we assume that the last Okazaki fragment hybridizes with the final base pairs of the lagging strand template, because the RNA primer is removed, there will now be a short region of unreplicated short strand DNA at the end of the chromosome. Thus, with each round of replication, the lagging strand would grow shorter by approximately 50 nucleotides. At some point, genes encoding proteins would be disrupted or actually lost. For mammalian cells, the solution is the presence at the end of chromosomes of telomeres, which are TTAGGG tandem repeats. Notably, the 3' end of each chromosome with its telomeres extends beyond the 5' end as short strand DNA. This structure compensates for the end replication problem. Telomerase is a ribonucleoprotein that is a reverse transcriptase encoding DNA from an RNA template. The enzyme carries its own RNA template, which is used to elongate the lagging strand. Clinical and laboratory features of aplastic anemia. The most common presentation of AA is petechiae on the legs, bruising, epistaxis, and menorrhagia because of decreased platelets. Anemia may go unnoticed because fatigue and weakness may be attributed to excessive activity. It is unusual for patients to present with fever, chills, and a localized site of infection because of granulocytopenia. The absolute reticulocyte count is less than 40,000 microliters, and the absolute neutrophil count is less than 1,000. A platelet count of less than 30,000 with depressed granulocytes indicates severe aplasia. A marrow aspirate is required and will reveal numerous spicules with fat-filled spaces and very few hematopoietic cells. A marrow biopsy is also necessary to confirm the lack of cells. If hepatitis immune cytopenia is suspected, screening for hepatitis A, B, and C and the Coombs antiglobulin test are needed. Treatment. Combination immunosuppression therapy, with anti-thymocyte globulin ATG and cyclosporin or stem cell transplantation are two modes of therapy. ATG reduces the number of cytotoxic cells by activating ATG-triggered apoptosis. Cyclosporin inhibits interleukin-2 production by T lymphocytes. Now let's discuss hemolytic anemias. Red cells can be destroyed because of intrinsic abnormalities, usually inherited. defects of the following: membrane enzymes that generate ATP or reduced glutathione, or disorders of hemoglobin synthesis, thalassemia and sickle cell anemia. Extrinsic disorders of the red cell are usually acquired, and causes include autoantibodies with complement fixation, infection by intracellular parasites, malaria, and babesiosis, toxins, clostridial sepsis, or snake or spider venom. The site of hemolysis has also been used as a means of classifying hemolytic anemias and is divided between intravascular hemolysis, in which the damaged red cells are destroyed within the circulation, or extravascular hemolysis, in which the red cells are phagocytosed and degraded by macrophages in the spleen, liver, and bone marrow. Destruction of red cells within the vascular compartment liberates hemoglobin into the bloodstream, and some hemoglobin appearing in the urine. A protein, haptoglobin, has a high affinity for hemoglobin, generating hemoglobin haptoglobin complex that is cleared by the mononuclear phagocytic system. Because there is a limited amount of circulating haptoglobin, most haptoglobin is tied up with liberated hemoglobin, and consequently free haptoglobin levels decline. Some of the remaining hemoglobin undergoes oxidation to methemoglobin, and some of this methemoglobin is excreted in the urine, imparting a red-brown color. The heme portion of hemoglobin is broken down to bilirubin by the mononuclear system, and if liver function is normal, elevation of serum bilirubin seldom exceeds 4 mg per deciliter. Extravascular hemolysis is the fate of red cells with membrane defects or decreased deformability because of a lack of adequate ATP or reduced glutathione or GSH. Because the red cells are destroyed in the liver, spleen, and bone marrow, hemoglobinemia, and hemoglobinuria are common. Membrane defects and hereditary spherocytosis. Red cell membrane phospholipids and proteins are asymmetrically arranged on the exterior and interior or cytosolic surfaces. Structural proteins are organized into a fibrous network composed of spectrin, actin, and protein 4.1. Spectrin monomers wrap around each other and bind to actin and protein 4.1. Altogether, this meshwork of proteins creates an internal membrane skeleton on the inner surface of the plasma membrane. The membrane skeleton is lashed into the lipid bilayer by linking proteins, of which the most important is ankyrin. Thus, it should be clear that a defect in any one of the proteins creating the meshwork or attaching it to the lipid bilayer can cause an abnormality in red cell structure and deformability. The result will be a red cell that no longer possesses the optimal biconcave dish shape. Recall that decrease in the ratio between the surface area and the volume of the cell will cause the cell to adopt a spherocytic form. Hereditary spherocytosis is an inherited defect in one of the proteins that attaches to the red cell skeletal system to the overlying lipid bilayer. Molecular defects in spectrin, ankyrin, band 3, and band 4.2 result in the cell becoming weakened with a loss of some membrane lipid as the red cell is exposed to shear stresses in the marrow capillaries. This loss of membrane gives the red cell no alternative but to assume a spherical shape because it represents the smallest diameter for a given cell volume. Notably, the common defects involve ankyrin or band 3 and not spectrin. These spherocytes become trapped in the splenic cords where they are destroyed by incoming macrophages. Clinical manifestations of hereditary spherocytosis range from mild hemolysis with bone marrow compensation, usually inherited as an autosomal dominant trait with only one abnormal gene, and severe hemolysis, usually autosomal recessive with two abnormal alleles. Jaundice and splenomegaly are common. The diagnosis depends on the presence of reticulocytosis pherocytes on the uh, peripheral blood smear and elevated unconjugated bilirubin. The osmotic fragility test is abnormal because these tests are vulnerable to swelling in a hypotonic environment. If splenectomy is to be performed, it should not be contemplated without administering polyvalent pneumococcal, meningococcal, and Haemophilus influenza B vaccines before the procedure. In fact, if the surgery can be delayed until after 5 years of age, the infectious consequences of the removal of the spleen will be mitigated. Red cell metabolic disorders, glucose 6-phosphate dehydrogenase deficiency. The pentose phosphate pathway only metabolizes 5 to 10% of glucose presented to the red cell, but it produces nicotinamide adenine dinucleotide phosphate, or NADPH, which is an essential cofactor for glutathione reductase. Glutathione reductase maintains glutathione in the reduced state so that it can detoxify reactive oxygen species, or ROS, including superoxide ion, hydrogen peroxide, and hydroxyl radical, which are continuously formed in the red cell because of the chemical interaction of oxygen and heme iron. In the absence of G6PD, the major source of NADPH for glutathione reductase is lost, and these ROS damage and red cell lipids and proteins and cause hemolysis. Glucose 6-phosphate dehydrogenase deficiency, or G6PD, is the most common inborn error of metabolism, affecting over 200 million individuals around the world. The high prevalence of G6PD deficiency in African blacks, Mediterranean, Arabs, Greeks, Italians, and Sephardic Jews, Indians, and Southeast Asians is believed to stem from the inhospitable environment provided by G6PD heterozygotes from malarial parasitism of the red cell. G6PD is also the most common X-linked enzyme deficiency, with males at much greater risk than females, who, because of lionization, are likely to have many normal red cells. Even if one X chromosome carries the defective gene, nonetheless it is possible for a female to have severe G6PD deficiency depending on the percentage of red cells affected. Pathogenesis. As noted, if G6PD is deficient, it cannot provide sufficient NADPH to maintain adequate levels of reduced glutathione to counteract the deleterious effect of ROS. Oxidative damage to membrane proteins leads to decreased deformability and hemolysis. Denaturation of globin in hemoglobin leads to precipitates called Heinz bodies, which cause further damage to the cell membrane. The most common abnormal variant is GDA-, in which only one amino acid differs from the normal wild enzyme. However, this enzyme is less stable than the normal GDA+. If a GDA- individual is exposed to an oxidant drug, acute hemolysis occurs immediately and targets older red cells with insufficient enzyme activity. Notably, even if the oxidant drug is continued, the pace of hemolysis slows because newer GDA- cells, which are pouring out of the bone marrow, possess enough enzymatic activity to generate sufficient NADPH to withstand the continuing oxidative stress. Hemolysis will wax and wane if erythropoiesis slows and the patient is again exposed to oxidative stress. This disorder was first identified in American troops in Korea in the 1950s, who were given prophylactic primaquine against malaria. Biochemical detective work uncovered the offending enzyme defect. Hemolytic episodes and abnormal red cells on peripheral smear with Heinz bodies and small membrane invaginations called bite cells suggest the diagnosis. The G6PD tetrazolium cytochemical test is the most sensitive test to detect G6PD deficiency. Treatment requires discontinuing the offending drug, but some patients develop hemolysis from oxidative stress associated with infections, presumably because of white blood cells liberating ROS as part of the assault against microbes. Pyruvate kinase deficiency. Pyruvate kinase deficiency, or PK deficiency, is the most common red cell glycotic enzyme defect, but it's far less common than G6PD deficiency. Because PK is one of two enzymes in glycolysis that generates ATP, and because the red cell has no mitochondria to carry out oxidative phosphorylation, loss of one of the two ATPs produced by glycolysis has wide-ranging effects on the red cell. Pyruvate kinase deficiency and the other glycolytic enzymopathies are not associated with abnormal erythrocyte morphology, including spherocytes, or with increased osmotic fragility. Anemia, jaundice, and splenomegaly are usually noted, and there is no association with oxidative stress, as in G6PD deficiency, because the defect is with generation of efficiency with energy of the red cell. Accumulation of glycolytic intermediates, especially 2,3-BPG and 3-PG, commonly help confirm the diagnosis of pyruvate kinase deficiency because these intermediates accumulate proximal to the blocked step. Pyruvate kinase is inherited as an autosomal recessive trait. The splenectomy improves the patient's condition but is not curative. Next, we will discuss sickle cell anemia. Sickle cell anemia, or SCA, is perhaps the most well-known of the hematoglobinopathies and was the first molecular disease to be identified in 1949. SCA causes hemolytic anemia and dysfunction of several organs because of vascular occlusion and compromise of the blood supply of those organs. The biochemical defect in sickle cell anemia, HBS, is a substitution of the hydrophobic amino acid valine for the hydrophobic amino acid glutamic acid, position 6 of the 5-globin chain. This is the result of a mutation of the 6th codon of the B-globin gene, in which GAC becomes GTG. Because the abnormal valine residue is positioned on the surface of the folded beta-globin chain, this sticky valine residue on each of millions of hemoglobin molecules with the red cell causes abnormal solubility and HBS to polymerize when the hemoglobin becomes deoxygenated. This leads to reduced deformability and sickling of many red cells with vascular occlusion by these clumps of sickled cells. Sickled red cells. Epidemiology. The persistence of the HBS gene in areas of high incidence of falciparum malaria are believed to be attributable to reduced survival of the parasite in red cells carrying the sickle cell trait. This phenomenon is called balanced polymorphism and reflects the selective advantage of the heterozygote over the homozygote. In the US, greater than 90% of patients with SCD are African American, with an 8% prevalence of the trait among African American newborns. There are approximately 50,000 individuals in the U.S. with sickle cell disease. It is striking that the prevalence of sickle cell trait in Western Africa is 25 to 30%, with 120,000 babies born with SCD in Africa each year. Clearly, this is a major problem for countries with meager medical resources for the patient with sickle cell disease. Pathophysiology. The solubility of deoxy-HBS is approximately 1/2 of that of HbA, which is 70% versus 34%. which is partially explained by the loss of a negative charge on glutamate and the gain in hydrophobicity of valine. Deoxy-HbS aggregates into densely packed polymers, while deoxy-HbA does not aggregate, but upon reoxygenation, the HbS depolymerizes. Cycling takes a finite time to occur. There is a delay between deoxygenation and polymerization that has been attributed to a nucleation process in which HbS tetramers form small aggregates that must reach a critical mass to form a tactoid, which is an elongated spindle. This intracellular polymerization of HbS causes red cells containing HbS to adopt sickle-shaped deformity. Sickle cells are more prone to dehydration than normal red cells, attaining mean corpuscular hemoglobin concentrations, or MCHC, of greater than 34 grams per deciliter and sometimes approaching 50 grams per deciliter. The dehydration is partially attributable to the distortion of cation transporter sites by bundles of HbS polymers. In addition, intracellular calcium is increased in sickle cells, and this drives potassium through a calcium-activated potassium channel, the Gardos pathway. It has been shown that 5 to 50% of cells from patients with sickle cell disease are irreversible sickled cells, ICSs, which cannot undo their abnormal crescent shape. Because of a low MCV and high MCHC, these cells are clearly dehydrated. Different patients have differing amounts of ISCs, and it has been shown that this is dependent on continuing production of HbF or A2Y2 that partially reduces the tendency to sickling. Adhesion of sickle cells and vasoocclusion. Sickle cells are more adherent than normal red cells to vascular endothelium, monocytes, and macrophages. Adherence to the vascular endothelium begins the process of occlusion, which is brought to its culmination by clumps of sickled cells obstructing capillaries and venules. Compounding the increased adhesiveness of sickle cells is the activation of platelets and of coagulation in sickle cell disease. There is evidence that tissue factor, the initiator of the extrinsic coagulation pathway, is increased by activated endothelial cells and monocytes. Further, some red cells absorb tissue factor that has entered the circulation. The end result is widespread vasoocclusive episodes potentially affecting any organ of the body. Pathogenesis and hemolysis. Extravascular and intravascular hemolysis contribute to the destruction of sickle cells. Extravascular hemolysis occurs by monocytes and macrophage phagocytosis of red cells that are reversibly sickled or have suffered oxidative damage to the cell membrane. Intravascular hemolysis, accounting for approximately 1/3 of hemolysis, is brought about by complement-mediated lysis of cells. Also, some cells are so damaged that they are destroyed by shear forces these cells encounter within the circulation. Clinical manifestations. Individuals homozygous for HbS do not usually manifest any symptoms until after 6 months of age. It has been shown to be dependent on production of sufficient amounts of HbF in those first 6 months to restrain HbS cells from sickling. After 6 months, the production of HbF wanes dramatically. One mode of therapy of sickle cell disease is to augment production of HbF later in life. Most patients are anemic by 4 months of age but suffer no symptoms. The first episode of vasoocclusion occurs between 6 and 12 months of age in approximately 50% of patients, and before 6 months of age in the remainder. Dactylitis and the acute chest syndrome are more common in the first year of life than thereafter, and as has been emphasized from a clinical perspective, vasoocclusive events dominate the clinical picture of SCA, sickle cell anemia, rather than anemia. Acute events in sickle cell disease. Sickle cell crisis refers to recurring accounts of pain caused by obstruction of the microcirculation by accumulating sickle cells. Historically, pain in the skeleton, chest, or abdomen was embraced in the term crisis, but now all painful events are included in that category. The hand-foot syndrome usually involves the small bones of the hand and feet, and is expressed as swelling and exquisite pain associated with fever and leukocytosis. The attack is sudden and may last for 1 to 2 weeks. After 3 years of age, these attacks are quite uncommon. Painful crises of larger bones, including the extremities, spine, ribs, and joints, may occur after the first few years of life. Stroke, cerebrovascular accident, or CVA, is a catastrophic feared complication of SCA and occurs in 6 to 17% of children and young adults. Not surprisingly, the risk of stroke is increased in patients whose HbF is less than 8%. Symptoms and signs depend on the vessel affected. Long-term transfusion therapy has drastically reduced the incidence of CVAs. Acute chest syndrome is characterized by tachypnea, chest pain, fever, leukocytosis, and pulmonary infiltrates. It appears that infectious causes predominate in children and occlusion in adults, but in many both are present. Penicillin prophylaxis and pneumococcal vaccines have greatly decreased the incidence of pneumococcal ACS, but Mycoplasma pneumoniae, chlamydia, and parvovirus 19 account for the remaining causes. Aplastic crises are transient stoppages of erythropoiesis and are characterized by an abrupt decrease in hemoglobin reticulocytes and red cell precursors in the marrow. Parvovirus 19 accounts for approximately 2/3 of aplastic crises. Acute splenic sequestration occurs when blood is trapped in the spleen of infants and youngsters whose spleens have not been shrunken by autoinfarction and fibrosis. Autosplenic sequestration is marked by a decrease in hemoglobin of at least 2 grams per deciliter, a brisk reticulocytosis, and acute enlargement of the spleen. Infection of the blood and CSF is caused by Streptococcus pneumoniae in the first 3 years of life, but has decreased dramatically with penicillin prophylaxis and pneumococcal vaccines. Osteomyelitis occurs more frequently in patients with SCA, is believed to be attributable to ischemia and infarction, furnishing a nidus for infection of the long bones, while in the general population, most cases of osteomyelitis are caused by Streptococcus aureus. In patients with STA, Salmonella predominates. It has been proposed that intestinal microinfarcts may lead to release of Salmonella and seeding of damaged bone. Diagnosis. Today, some states include screening for HBS as part of a newborn screen. HBS is a distinctive mobility on citrate agar electrophoresis and pH 6.2, and the solubility tests Sickledex can distinguish HBS, which is not soluble, from HBD and HBG, which are soluble. Chronic organ damage. The height and weight of children with SCA are delayed relative to age-matched standards, and pubertal onset is delayed by 2 years. Notably, by adulthood, both genders have achieved normal or near normal height, but the weight is still lower than predicted by growth charts. A suggestion to explain the weight gap is that the chronic hemolytic state with protein turnover imposes a high resting energy requirement, which presents an excessive metabolic burden. Children who have suffered overt or silent strokes show evidence of cognitive impairment. Subclinical cerebral infarcts can be demonstrated by MRI and Doppler flow studies. Pigmented gallstones develop because of the chronic hemolysis. Liver dysfunction may develop as a consequence of transfusion-acquired viral infections and iron overload. Because the blood supply to the renal medulla is often reduced by occlusion, Impaired urinary concentrating ability is common. If transfusions are begun before 8 years of age, this concentration defect can be reversed. Priapism, spontaneous painful erections, occurs in as many as 40% of males in some series and can be prevented by the oral alpha-adrenergic agent acetylphrine. Retinal artery occlusion and proliferative retinopathy are not infrequent complications in patients with SCA. Osteonecrosis may cause compression or collapse of vertebrae and bones of the hands and feet. Leg ulcers are usually seen near the malleoli arising from trauma. The chronic anemia state is compounded by increased cardiac output and increased heart size. Overt heart failure is uncommon. Myocardial infarction has been documented in 10% of patients dying with SCA. Treatment. Transfusion therapy is a major therapeutic modality to reduce sickling and prevent vaso-occlusive episodes. Iron detoxification must be provided for patients on chronic transfusion programs. Pain management is an essential aspect of care, as is prompt treatment of infections. Okay, so let's continue with the thalassemias. The thalassemias are a group of inherited defects in the synthesis of the alpha or beta globin chain subunit of the hemoglobin tetramer. While a microcytic anemia is a feature of these disorders, the accumulation of globin subunits that have no opposite to partner will lead to precipitation with damage to red cell precursors and ineffective erythropoiesis and severe hemolytic anemia. There are believed to be greater than 250 million people who are carriers for a thalassemic gene defect, making it the most common single genetic disorder. By convention, alpha chains are reduced or absent in patients with alpha thalassemia, and beta chains are reduced or absent in patients with beta thalassemia. When no chains are produced, the disorders are designated as the alpha or beta, looks like a theta, the one that says alpha 0, beta 0, and when production is reduced, alpha plus or beta plus. Thus, the thalassemias represent quantitative disorders reflecting decreased or absent production of alpha or beta globin chain synthesis. Genetics. The genes for the alpha globin cluster reside on chromosome 16, and those for the beta globin cluster are in chromosome 11. There are 4 genes for alpha globin synthesis. The alpha thalassemias are usually caused by deletion of 1, 2, 3, or 4 alpha globin genes. In contrast, there are 2 genes for beta globin, and most types of beta thalassemia are caused by point mutations affecting 1 or 2 bases. Genetic processes that are distributed in beta thalassemia include abolition of normal splicing of exons, creation of nonsense stop codons, or alteration of the reading frame if less than 3 or multiples other than 3 are inserted or deleted. Remember, codons are triplets. In both alpha and beta thalassemia, regardless of the underlying gene defect, there is unbalanced synthesis of the individual alpha or beta subunits. It is the abnormal behavior of these unpaired globin chains that accounts for much of the clinical manifestations. Free or unpaired alpha subunits are very insoluble and precipitate, thus damaging the red cell. Beta and gamma globin HbF chains form tetramers, gamma forms of hemoglobin Barts, or beta chains from HbH, which bind oxygen so tightly as to prohibit release of oxygen. So let's talk about beta thalassemia. To repeat, the basic defect in beta thalassemia is reduced or absent production of beta globin chains causing an excess of unpaired alpha chains. Beta thalassemia occurs primarily in individuals of Mediterranean European descent. In these patients, hemoglobin production is decreased and assembly of the normal alpha and beta tetramers is drastically reduced. It is this imbalance in globin chain synthesis that results in ineffective erythropoiesis and the premature destruction of damaged red cell precursors in bone marrow. Studies have shown that only 15% of radioactive iron is incorporated into circulating erythrocytes in the beta 0 thalassemia, indicating that the vast majority of iron is wasted in ineffective erythropoiesis. The process underlying the ineffective erythropoiesis involve the processes underlying the ineffective erythropoiesis involve precipitation of free alpha-globin chains with formation of inclusion bodies. These inclusions cause structural and functional changes in deformability and stability of the red cell membrane, which undergoes oxidative damage and is destroyed by apoptosis. The hyperchromic microcytic anemia and ineffective erythropoiesis together constitute a powerful stimulus to erythropoietin production. Consequently, the marrow is driven to produce more red cells, but the process is futile because of the staggering wastage of cells destroyed by ineffective erythropoiesis. Before therapeutic red cell transfusion programs were instituted, this resulted in massive bone marrow expansion with chipmunk faces because of expansion of marrow in facial bones. The encroachment of expanded marrow on bone causes osteopenia. Institution of a regular transfusion program to maintain hemoglobin between 9 and 10 grams per deciliter improves oxygen delivery and thereby reduces the drive for ineffective erythropoiesis. The addition of iron chelation therapy has further prolonged life, but not in the population norms. It is important to recognize that infants with beta thalassemia are usually protected by production of HbF or A2 gamma 2 in utero and in the first 6 months of life, and therefore do not manifest anemia. If untreated by transfusion, clinical manifestations appear in the second 6 months of life with pallor, irritability, slowed growth, hepatosplenomegaly, and jaundice. All of these features can be prevented by instituting a transfusion program, which are now common in the industrialized world. Laboratory findings. Thalassemia major or beta 0 thalassemia manifests as severe hypochromia and microcytosis because the cells are under hemoglobinized with a hemoglobin of less than 5 grams per deciliter. On the peripheral sphere, there are abnormal red cells forms with microcytes, poikilocytes, teardrop cells, and target cells. The cells are markedly resistant to hypotonic sodium chloride, and hemoglobin electrophoresis is necessary to establish the diagnosis and reveals HbF. Bilirubin is in the 2 to 4 milligrams per deciliter range. Treatment. Regular transfusion associated with chelation therapy or desferoxamine or deferoprone has improved the life expectancy to the 40s, a dramatic improvement over pre-transfusion therapy. Bone marrow transplantation, when successful, is curative. Population screening and prenatal diagnosis. Population screening of high-risk populations has been instituted in the Mediterranean region. A dramatic decrease in birth of infants affected with beta major thalassemia has been accomplished in Sardinia as a result of these screening programs. The optimal time for assessing genetic risk is before conception. Prenatal diagnosis is possible by using fetal DNA obtained between the 8th and 18th week of gestation. With this information, some couples will choose to bring to term fetuses unaffected by beta major thalassemia. Alpha thalassemia. Like beta thalassemia, the primary defect of alpha major thalassemia is reduction or absence of alpha globin chain synthesis with excess of beta, gamma, or both chains. Unlike alpha chains which accumulate in beta thalassemia and precipitate, excess gamma chains in the fetus associate to form a partially soluble gamma-4 tetramer called HB-BART. This hemoglobin holds on to oxygen tenaciously with an affinity akin to that of myoglobin, having an oxygen dissociation curve shifted to the left, releasing no oxygen to the fetus. This causes severe hypoxia, congestive heart failure, hydrops, which is severe edema, and death in utero or soon after birth. Hydrops fetalis with HB-BART is found predominantly among Asians. HBH is caused by deletion of 3 of 4 alpha globin chain genes with a globin production approximately 25% normal. Excess beta globin chains accumulate after birth, and the excess beta globin chains form beta-4 tetramers called HBH. HBH precipitates in mature red cells, causing a moderately severe hemolytic anemia. Ineffective erythropoiesis is not a prominent feature of HBH disease. Some patients with HBH not require regular cell transfusions and chelation therapy. Patients with 4 alpha gene deletions who survived to birth can undergo exchange transfusion or in utero blood transfusion. Now let's talk about autoimmune hemolytic anemia. The autoimmune hemolytic anemias, or AIHAs, are a group of disorders in which antibodies against self-antigens located in the external surface of red cells trigger hemolysis. Classification of these hemolytic anemias usually rests on the temperature-related activity of the antibodies. Thus, there are warm antibodies that react at 37 degrees centigrade of the IgG class and do not fix complement. These are primary and secondary causes for the development of the antibodies. In contrast, cold agglutinins are usually of the IgM class and are most active at cold temperature of 18 degrees centigrade. These antibodies dissociate from the erythrocyte's membrane at temperatures of greater than 30 degrees centigrade, accounting for the reactivity in the cold. Because the antibodies are IgM, the antibodies are efficient in fixing complement. Finally, there are rare cold hemolysins, which are responsible for paroxysmal cold hemoglobinuria. Currently, paroxysmal cold hemoglobinuria occurs in children after a viral infection, but in the past, paroxysmal cold hemoglobinuria was associated with tertiary syphilis. These antibodies are IgG and usually target the P blood group system. Diagnosis of autoimmune hemolytic anemia. Agglutination refers to the clumping of red cells as a result of interaction between membrane antibodies and specific antigens. IgM antibodies are larger than IgG. IgM is a pentamer with a span of approximately 35 nanometers. IgM is able to bind 2 red cells that would otherwise remain apart because of a negative surface charge on each red cell. The charge is called a zeta potential and usually produces a gap of approximately 25 nanometers between any 2 erythrocytes. In contrast, the maximum span of the IgG molecule is approximately 14 nanometers, far too short to bring about agglutination of the neighboring red cells. The practical implication of these different properties of IgM and IgG are that IgM antibodies can be detected by agglutination reactions between test sera and red cells suspended in saline, whereas IgG antibodies require a bridging substance that will connect the antibody molecule on separate cells to bring about agglutination. This substance is Anti-human globulin, or AHG. AHG is anti-human globulin is a broad-spectrum antisera produced in rabbits that reacts against human IgG and complement. The antibody contains FAB and FC binding sites, allowing the FC end to attach to IgG or complement. The AHG, or Coombs test, is used in the following two situations: to detect red cells coated with antibody, which is termed the direct test, and to detect antibodies in serum, which is termed the indirect test. The direct antiglobulin test, or DAT, detects red cells to which antibodies or complement has been bound. Patient cells are washed to remove traces of plasma protein. Then the AHG to IgG and complement is added to the saline washed patient cells. If the patient cells are covered with IgG and complement, the reagent will cross-link the cells and will agglutinate. The indirect antiglobulin test, or IAT, is used to detect antibody in the patient's serum. In this version of the test, the red cells are of known antigenic makeup, usually obtained commercially, and are used to determine if patient serum plus AHG plus commercial red cells will cause agglutination. Performing these tests at various temperatures helps to define whether or not a warm or cold antibody is responsible. So let's talk about warm autoimmune hemolytic anemia. Warm autoimmune hemolytic anemia is the most common type of immune-mediated anemia, accounting for approximately 70% of cases. Nevertheless, AIHA is not common, with an incidence of about 1 per 80,000. About one half of autoimmune hemolytic anemia cases are idiopathic, while the other half occurs in patients with underlying immune disturbances and are termed secondary. Secondary causes of autoimmune hemolytic anemia include lymphomas and leukemias, systemic lupus erythematosus, ulcerative colitis, and other autoimmune diseases and drugs. As noted, because hemolysis occurs at a normal body temperature, these are warm antibodies of the IgG class. These IgG-coated red cells find Fc receptors expressed on macrophages, and these macrophages remove small portions of the membrane, thus forcing the cells to become spherocytes. These less deformable cells are removed in extravascular sites, particularly the spleen. Splenomegaly is a feature of warm autoimmune hemolytic anemia. These patients are anemic with a reticulocytosis, and on the peripheral smear, polychromasia and spherocytes are observed. Unconjugated bilirubin may be elevated. The DAT is positive and confirms that autoantibody, complement, or both are present on the patient's red cells. Treatment. Because transfusion is complicated by the difficulty of finding completely compatible cells, and because of decreased survival of transfused cells, other modalities of therapy are preferred, including glucocorticoids, which decrease sequestration of red cells in the spleen and decrease antibody production. Rituximab, a monoclonal antibody against CD20, has been used in refractory autoimmune hemolytic anemia and is being considered as an alternative to splenectomy, which has a number of complications, including increased risk for sepsis from encapsulated organisms. Next is cold agglutinin hemolytic anemia. This form of hemolytic anemia is caused by IgM autoantibodies that bind to red cells at low temperature of 14 to 18 degrees centigrade, but rapidly associate from the erythrocytes at 30 degrees to 77 degrees centigrade. As noted earlier, IgM antibody is an efficient activator of the classic complement pathway. These autoantibodies occur in patients with B-cell lymphomas, chronic lymphocytic leukemia, and Waldenstrom macroglobulinemia. This form tends to be chronic. An acute form is rarely seen as a complication of mycoplasma pneumoniae or infectious mononucleosis. Symptoms arise at sites where the blood is cooled, such as the fingers, toes, and ears. If these sites are warmed, hemolysis can be aborted or mitigated. The acute form is self-limited, while the chronic form will require the care of a hematologist or oncologist. Next, paroxysmal cold Hemoglobinuria. Paroxysmal cold hemoglobinuria is a rare form of immune-mediated hemolytic anemia, and hemolysis is complement-dependent. The IgG autoantibody, known as the Donath-Landsteiner antibody, binds to the P group antigen on the red cell at low temperature. In a group of children with AIHA, only 6% suffer from this type. The children had a history of an antecedent viral or mycoplasma infection. In this disorder, both the DAT and IAT are negative. Therefore, the diagnosis depends on excluding other causes and recognizing the clinical setting in which hemolysis occurs. This is a difficult disorder to treat because there is no specific therapy. And now we will make a few comments on the case. With an MCV of 124 micrometers cubed, this patient has megaloblastic anemia attributable to a defect in DNA replication. This process requires vitamin B12 because methylcobalamin donates an essential methyl group to tetrahydrofolate to regenerate the folate species necessary for the thymidylate synthase reaction. That reaction converts DUMP to DTMP. Blockade of this reaction leads to miscorporation of uracil into DNA, which eventually leads into breaks in the DNA helix. This patient most likely has pernicious anemia resulting from autoimmune atrophic gastritis. One consequence of this autoimmune destruction of gastric parietal cells is loss of intrinsic factor. In the absence of intrinsic factor, vitamin B12 cannot be absorbed in the distal ileum. Other features of autoimmune gastritis associated with pernicious anemia are achloridria and low serum peptinogen. It appears that the progression of type A autoimmune gastritis takes at least 20 years to unfold. Serum gastric parietal cell antibodies are associated with autoimmune gastritis, notably hydrogen potassium ATPase is the antigen that is attacked by parietal cell autoantibodies. Although no longer frequently performed, an abnormal Schilling test will demonstrate that vitamin B12 deficiency is a result of intrinsic factor deficiency. This test measures the amount of orally administered radioactive vitamin B12 that is absorbed in the gut and excreted in urine. Today, because of problems with radioisotope disposal, methylmalonic acid and homocysteine levels are preferred tests for the early diagnosis of B12 deficiency, including that caused by pernicious anemia. Patients with pernicious anemia must be treated with IM injections of vitamin B12 because they cannot absorb the vitamin from the gut.